Good afternoon. This is Laura Bauer, Director of National Initiatives for the Rosalind Carter Institute for Caregiving, and I welcome you to our webinar, Increasing Awareness of Elder Abuse to the Caregiving Field, which will be presented by the National Center on Elder Abuse. Before we get started, I'm going to give you a couple of logistical things, and then I'll introduce our presenters. We're going to do questions and answers at the end. So as this goes along, if you have a question, go ahead and type it into the chat. I will keep an eye on that, so when we're getting close at the end, I can scroll through those questions, see which ones have been asked maybe by more than one person. We'll get to as many of those as we can. So we're going to leave everyone except the presenters muted for now. We will have someone from the Georgia Department of Aging Services, Georgia Division of Aging Services, join us at the end for just a couple of minutes. But without any further ado, I want to go ahead and introduce our presenters. We have Bonnie Olson, who is a licensed clinical psychologist and professor at the University of California, Irvine, Department of Family Medicine, program in geriatrics, where she's been affiliated for the past 15 years. She conducts clinical assessments of geriatric patients and helps families manage caregiving demands. She also works with the Elder Abuse Forensic Center, where she conducts assessments pertaining to elder abuse. Dr. Olson is involved with several grants that are designed to help us understand how to best support caregivers of patients with dementia. We also have Mary Toomey, who is co-director of the Center for Excellence on Elder Abuse and Neglect at the University of California, Irvine, Division of Geriatric Medicine and Gerontology. UCI Center of Excellence also serves as the National Center on Elder Abuse, which Mary also co-directs. Mary has her master's in social work with a concentration in gerontology and mental health, and she is a long-distance caregiver for her mother. And so right before we get started, I also want to mention that coming up very soon, June 15th, is World Elder Abuse Awareness Day. So I want everybody to keep that in their mind. There's going to be a world celebration. It's every year on June 15th, so it's a very good time for us to be hearing more about increasing awareness of this issue. Ladies, go ahead.
Thank you so much, Laura, and thank you to everyone who is attending this webinar. This is Mary Toomey. I'm really happy to be here with my friend and colleague, Dr. Bonnie Olson. Hey, Bonnie.
Good morning. Well, I should say good afternoon to those of you who are on the East Coast. This is Bonnie Olson, and I'm delighted to be here as well.
So,
and Mary, if you could speak up just a bit.
Of course, I can always speak up. So I'm really, really happy to be on here today, here talking with all of you about increasing awareness of elder abuse to the caregiving field. You know, I want to start by recognizing it's not a really easy topic to talk about, and so we commend the Rosalind Carter Institute for Caregiving for hosting this webinar and bringing us together to have this dialogue, and we really, really appreciate our partnership with them. So thank you, Laura, and thank you to Dr. Esom as well. You know, I think I wanted to start by just saying that caregivers, whether paid or unpaid, you know, in my opinion, are really the backbone of our nation's long-term care system, and they provide compassionate assistance and support for millions of elderly and adults with disabilities in our country. And that's why it makes me so happy and excited to be able to talk to you all today, because you as caregivers, or the caregivers that you work with, are in a unique position to see signs of elder abuse and neglect. And also, we also wanted to talk a little bit today about how, if you are a caregiver or working with caregivers, how do we help caregivers see the signs, not only in others who may be providing care, but also see the signs where they themselves, when the going is getting tough, when they themselves may be getting close to crossing the line to doing things that they would later regret. So let me advance the slides. You know, I can't do two things at once, talk and advance slides. There we are. And I thought it would be good to start with, at the beginning, to start with a common understanding of what is elder abuse, what is it that we're talking about. And I would also say that along the way we may use abuse and neglect. We consider neglect a type of abuse. And also sometimes we use a word like elder mistreatment. For me, those are synonyms, abuse and mistreatment. I think we may be, as a field, moving more towards slightly softer language like mistreatment. This definition comes from something called the Elder Justice Roadmap Project, which the report about that project will be released on Monday for World Elder Abuse Awareness Day. And this is a project that was co-sponsored by the Department of Health and Human Services and the Department of Justice, and brought together about 750 stakeholders who did many things. Among one of the great things they did was to synthesize a lot of information to come up with a definition of elder abuse that looks at a number of things. It looks at the types of elder abuse, where elder abuse occurs, so the settings, and in what kinds of relationships. So we consider this to be a really excellent definition. So we're talking about elder abuse as physical, sexual, or psychological abuse. It also includes neglect, abandonment, and financial exploitation of an older person by another person or an entity. It can occur in any setting, and it occurs either in a relationship where there is an expectation of trust, so with a family member, with a fiduciary, with a person in a clergy position, or when an older person is targeted because they are perceived to be more vulnerable, more easy to dupe, more easy to take advantage of because of age or disability. I'm going to turn it over to Bonnie for a quick second.
Okay, thank you, Mary. As I listen to the definition of elder abuse, I think that myself and many others often, excuse me for my voice being scratchy, I think many of us think about abuse as being something that happens when, sort of a bad person does bad things. And indeed that is what we see often, but it's not always that. Many times elder abuse happens in very subtle ways, and often it happens unintentionally when someone is doing the best they can, but it crosses the line and it becomes inadequate, or it actually becomes abusive. So I just wanted to point that out to the audience, that sometimes it really is horrible, bad things that bad people are doing, but not always. And that really any of us are capable of crossing that line when we're in the right or whether when we're in the wrong circumstances, or in a position where the demands exceed the resources we have available to us. So I'll hand it back to you, Mary, and you can talk a bit more about what elder abuse looks like sort of across the country.
Right. So those of us who work in elder abuse and elder justice really consider this a silent epidemic. So how big a problem is elder abuse? Research from 2010, a random digit dialing survey of community dwelling seniors, 60 and over, found a very high percentage of elder abuse, so as almost as high as 10%. So 1 out of every 10 older Americans have experienced in the last year, the year that this study was done, elder abuse. And another interesting point is that many of them experience several kinds of abuse. And what I think is interesting about this point is that the elder or adult with a disability who is abused, just like many children or people involved in domestic violence, have an experience where they feel like they've caused the abuse somehow. So there is a lot of minimizing on the part of the person who is abused or neglected. There's a lot of denying. If someone is telling you that they have had some money taken from them, which for some reason seems like a more palatable kind of abuse for people to disclose to others, to social workers, to their physician or a nurse. If somebody is telling you that something bad has happened to them, it's likely that more than one bad thing has happened, or more than one kind of bad thing has happened. So I just mentioned that in case some of you are in a position where you may be hearing people disclose, but also recognize that often when folks are disclosing that they're minimizing what has happened, or if you suspect that abuse has happened and you inquire, and we could talk a little bit about how to inquire about whether someone has been abused, that you may actually get a flat-out denial because of lots of things, including the fact that they believe that they've done something wrong, that they've been made to believe that they've done something wrong, or they don't want to get the perpetrator of the abuse in trouble. So chances are that you know someone, if you work with elders or adults with disabilities, who is experiencing or has experienced abuse. So elder abuse is a public health issue, and when we look at incidents, we see that for every report of abuse that is made to Adult Protective Services or to law enforcement, there are as many, according to a study done in New York in 2011, as many as 23.5 cases that never come to light. So for me, that means that there are a lot of people suffering, and that's why I do this work, because I want to try to ease the suffering of elders and adults with disabilities in America. So it's a really hidden issue, and that's why it's so important that we're all talking about it around World Elder Abuse Awareness Day and every day. So just like the other types of family violence, child abuse, and domestic violence, elder abuse has really significant consequences. We're also starting to see some research where we're looking at what if we know that if we follow children who have been abused into late life, we're finding lots of health issues that attend that child through as he or she becomes an adult. We also are seeing multiple kinds of abuse. If a person has been a victim of abuse as a child or as somebody in a relationship where there's domestic violence, that there is a greater chance that they will experience elder abuse as they grow into old age. So we see huge impact on health. People are twice as likely to be hospitalized. They're 4 times more likely to go into nursing homes. And this, just by the way, is research that's brand new. Some of it came out just last summer. There's a lot of impact on health and mental health. And then there's a big impact on our economy. We know that about elders lose about $2.9 billion a year to financial abuse, and that is probably significantly underreported, again, because of people's fear. They tell their family that they lost money to a scam or a sweetheart, somebody pretended they were in love with them and got money from them. They are afraid to tell the family that because they're then afraid that they're going to be considered senile. And we also know that elders who are abused have a mortality rate that's 300% higher than elders who are not abused. So the impact of elder abuse on individuals is significant. And I think it's important to know, like in the study that looked at the question of mortality, this was not that people died as a result of being hit. It didn't matter the kind of abuse nor the severity of that abuse. It was just the fact that they had been abused, mistreated, or neglected that was linked to the increase in mortality rates. And just a moment on the characteristics of victims, because I think Bonnie will have a chance later to talk a little bit about some of the research that we're doing at the University of California, Irvine, looking at what are the contexts for when abuse occurs, or is it at high risk of occurring? One of the things we're looking at is who are the victims, and what can we learn about victims, what can we learn about people who do cross that line and mistreat elders in their care, and what is important about the context. But in terms of victims, the older you are, the more likely it is that you'll be abused, 2 to 3 times more likely that people over 80 than their younger cohorts. There's a really high connection between folks who have dementia or other kind of cognitive impairment and mistreatment. They are more likely to be women, And this is interesting and important, that if they themselves, if the care recipient or the older person is physically or psychologically aggressive, that increases the chance that they will become victims of abuse. And this might be a nice moment for me to acknowledge that that caregivers themselves will often report that they have been abused. And I think that we want to acknowledge that is true, that sometimes care recipients, because of dementia or other cognitive illnesses, may strike out, may be verbally aggressive, physically aggressive, and that the abuse can go both ways. Today, we're talking about abuse of the vulnerable adult. But I do want to recognize that many caregivers that we talk to will say, I feel like I'm being abused too, and that's important. So I started a little bit at the top of our time together talking about why is it important for caregivers to know about abuse. And I think I was thinking about it sort of like three roles. Caregivers are sentinels, so you are in positions to know lots and lots of people and to detect elder abuse, signs of elder abuse or neglect. So you're sentinels, you may be the only other person who sees that elder or that adult with a disability. You're also supports. You're in positions to support other people who are providing care to help them learn what are the signs of abuse, what are the signs in themselves that they need to learn so that they don't cross that line. And so you are in a position to be supporting them and then teaching them about self-awareness. So I came up with 3 S's. You're sentinels, you're supports, and you're there to help people understand about self-awareness, what is going on with them, what are the warning signs in their own, in themselves, that they may be about to cross a line and go into some sort of activity, some sort of behavior that we would say was mistreatment. So I'm going to turn it over to Bonnie, because I know, Bonnie, you've been a caregiver for family members, and you've worked with caregivers for years, so I wanted to turn it over to you now.
Okay. Thank you, Mary. I think that was very helpful to give us all the sort of the context of what elder abuse looks like in the context of caregiving. As Mary mentioned, I was a caregiver for my mother, who has since passed away from Alzheimer's disease. And then I've worked with, probably hundreds of families that try so hard every day to provide the care that an older individual needs in their home or in a facility in the community. So I think I have a perspective on it, and I think I have been able to create some ideas that help people do a better job. And that's kind of where we're going to turn to right now. So to start off, I guess, caregiving is clearly an extremely rewarding experience most of the time, but the challenges are significant. And so I've spent some time thinking about and coming to understand a bit about why is it so hard? Because people really do struggle with this. What makes caregiving such a tough role to fulfill? And I think one of the primary things is that as a caregiver, we tend to be somewhat unrealistic of our own limitations, so that we set ourselves up to think that we're going to be able to do more and do it longer. So we have these unrealistic expectations that then when we fall short of that, we feel guilty, we feel badly, we're not able to sustain that. We also can, as a caregiver, become physically exhausted and tired, and that clearly limits what we're, I'm going to need a sip of water. We're going to clearly need some help in order to keep going in that caregiving role. Often caregivers neglect their own health care. They put aside needing to go to the physician or needing to attend to their own needs, and then find that their own health starts to decline, which then affects their ability to be a caregiver. As we'll be talking as we go along, the frustrations and irritability that can come out of exhaustion and difficult behaviors to manage is palpable. It is something that if you don't, as a caregiver, kind of get your hands around, it can become a problem. Caregiving is often done on a one-to-one basis. So as a caregiver, you're at home with a care recipient, or you're in an environment where you don't have a lot of social support immediately available to you. So that isolation alone, that feeling of I'm doing this alone, I don't have somewhere to turn to for assistance or help, can make whatever is going on feel even bigger or louder or stronger, make it much harder to manage. And as I mentioned, that sense of guilt when we don't quite meet our own expectations, or a sense of depression can be very strong, and it can make it even harder to provide the care that you're wanting to do. So these are just some of the ideas about what leads to the challenges in the caregiving role. So Mary, I think you're going to advance the slides for me. There we go. Okay, so what I've done is tried to develop a framework to give to caregivers to help them think about these challenges, and then develop a strategy to respond to particularly difficult behaviors, so that they don't get in that position where they feel like they're overwhelmed and something bad could happen. That elder abuse or mistreatment, it creates that environment where that can occur more readily. So this is sort of a framework, a way of thinking about things. So this is sort of the structure of it. We start with the caregiver, him or herself. That the idea is that first off, you have to identify how you feel as the caregiver at that moment. And I'll talk about that in a bit more depth as we go along. The second part would be to identify the problem behavior that needs to be addressed, and to think about that behavior in terms of the consequence to the behavior. So that's the part that comes from the care recipient. What's going on right now? What behavior is being displayed? And what's the consequences to that behavior? And we'll spend a fair amount of time addressing that in a moment. And then the third part would be to think about contextual issues that impact both of you, the care recipient and the caregiver. From the research we've been doing recently, we've come to understand that if you just think about the caregiver or the care recipient, or the elder adult who's being abused, and the abuser or the trusted other or the other person who's perpetrating the abuse, and you don't take into consideration the context, that you really miss some important things. So I wanted to include that here as an important piece of the overall picture that will lead you to then decide on an approach that makes sense and will be effective. And effective both in managing the behavior and avoiding what could have ended up in a mistreatment or an abusive situation. Okay, and then on the next slide, we'll turn to the first part of those sort of 4 steps there, which have to do with the feelings that the caregiver, or the emotional reactions that the caregiver might experience in the caregiving arena. Sometimes we get angry. As a caregiver, we can be angry at behaviors related to particularly dementia. And I'm going to stop here for a moment and just mention, I work with caregivers who are caring for someone who is suffering with dementia often, but not exclusively. There's also people who are in the caregiving role with individuals with other kinds of neurologic diseases like Parkinson's disease or post-stroke, or sometimes it's younger folks who have brain injury or have a developmental disorder. So there's a huge range of situations or problems that we might be in a caregiving role for. I'm going to frame my comments here and the structure around dementia because it's, for me, and in the context where I see patients and work with elder abuse, it's the most common one. But I just want to mention that it's not the only one or the only kind of disorder that leads to these vulnerabilities. But I will be talking about it as if it was just dementia. So please pardon that, and where you can, if you can extrapolate to those other disorders, please do so. I intend it to be more generalizable than just dementia. Okay, so that said, I will go back to these emotional reactions. I think one of the things that I hear about from caregivers is the feeling of when we go out in public or when I take my loved one who I'm caring for out, I feel both embarrassed for them, and I can see, and I imagine they must feel embarrassed as well. And so there's that piece that gets pretty difficult to manage. And then you can see all of the other ones, the fear of what lays ahead, depression and isolation that can come from the caregiving role. It could be grief about the losses involved, not necessarily death, but the loss of the personhood of the person you're caring for. Fatigue is often you're right there at your side at most any moment because this is such hard work. And hopefully those negative or more difficult emotions are balanced out with feelings of gratitude and peace and some enjoyment. There's those moments of pleasure that come along, and when we can wrap our arms around them and really embrace that, they're palatable and sustaining. The sense of satisfaction and that we're doing something really meaningful and worthwhile, and the sense of resolution that we've found something that's meaningful for us to do, and that this situation is where we want to be. We're resolved to it. So those emotional reactions can be complicated and multivariate all at the same time. We don't experience emotions one by one, but in lots of combinations. Okay, so if we move to the next step of identifying problem behaviors in the care recipient, I like to think about this in sort of three levels. And I have found in my work that this is really helpful for caregivers to give them a context, a way of structuring their thinking so that then they can dial in and get the right response to the right behavior. It can be very freeing, and also it can be very empowering to know this is something I really need to react to now. So I like to divide problem behaviors into three levels, if you will. The first level is irritating. There are things that folks with dementia or other disorders do that really is irritating, but it doesn't cause anything really negative to go on. There's no strong negative consequence. The second level would be where there is a negative consequence to the behavior, and it's either going to happen right now as it's unfolding, or there's a consequence that will happen over time as this behavior persists over a longer period of time of days or weeks. And then lastly, the third level would be where there's an imminent danger right now. It's a crisis situation, and you really need to respond immediately with some thoughtful intervention that's going to keep everybody safe. So I'm going to take these one by one, these 3 different levels, and sort of walk us through what does the behavior look like and what are some reasonable responses to it. So, and I'm going to use sort of some examples and cases to kind of illustrate these ideas. So a level 1 kind of behavior that I think of as just irritating, the most common one in the dementia setting is the repetitive questions or repetitive behaviors. Could be pacing, could be shadowing, could be those repetitive questions of what are we going, or when are we doing this, or what's going on, or when, just the varieties of them are endless, but they're very repetitive and they can be extremely irritating. There are folks who have dementia that engage in sort of ritualistic behaviors, packing and unpacking the purse, or taking everything out of the drawer and then putting it right back in again, doing things over and over and over again, sleeping too much or watching TV too much, not helping in the house, not engaging in household activities that they once did and that the caregiver might feel like they're completely capable of doing, but they just are not doing it any longer, which then creates more burden for the caregiver. A lack of response to the caregiver's needs or feelings, sort of a sense of insensitivity that can be very irritating, like, don't you understand, we just came back, I'm tired and I need to rest a little bit too, when there's a demand to do something else, or a refusal to go do something like take a bath or change clothes. So those are sort of the behaviors that I would put in the irritating, difficult, but not really creating a negative or dangerous consequence. So how would I encourage caregivers to respond or react to them? You might want to distract and redirect. That should be sort of a motto that caregivers carry around like their best friend. If you can distract and redirect, you're going to be in a better position to manage the behavior. If you can use humor, that often helps disengage a person with dementia from an irritating behavior so that it just kind of stops. If you can say something funny or lighthearted to pull their attention in a different way. What I encourage caregivers to do is to ask themselves the question, can I live with this? Is this a battle I want to fight? Is this a battle I can win? And is it something that I can just look the other way or engage in myself some other way so that I can just let it unfold? Do I really need to respond to it? And I don't always know the answer to the question, but it really is important to be asking it. Because if it's not a behavior that you have to intervene in, maybe it is at that moment the best thing is to just move away and let it unfold and not intervene. I'm going to give you an example of that kind of experience. Often with providing care for my own mother, she would ask repetitively, so what are we going to do today? What are we going to do today? And at the beginning of the day I would give the response, oh, today we're going to be doing X, Y, and Z, or we're going to go out and do that, or we're going to have lunch and then we're going to sit down and watch a movie, or what is it whatever the plan was. And inevitably within 2, 3, or 10 minutes I would have the same question again. And I learned after some time that if I allowed myself to get irritated with that, if I responded every time the question was posed in short order, I would be pretty short-tempered. And that happened more quickly the more tired I was. So I found that I needed to make sure that I did get enough rest and that I had enough other things to do to distract myself from those questions, that then they weren't as irritating. And then I could just not answer. I could just say, hey, look at this, or distract with another activity. So I just offer that as an example of sort of what my learning curve was about how to respond or not to respond to those sort of level 1 behaviors. Okay, then moving on to level 2. These are behaviors that often require something to be done because there are consequences to them. These are things like refusing to take a bath, brush teeth, take medications, eat meals, go to social activities, get in the car. There's a refusal to do something that is important, or either right now or over time we're going to run into trouble. Or alternatively, the demands are that the person with dementia or the care recipient is demanding to do something that is not good, like getting in the car and driving when they shouldn't be, spending money that they don't have or don't need to be spending, when they're up all night pacing, doing things that they really need to be resting and sleeping, or sometimes it's things like drinking too much, having alcoholic drinks that you know are not in their best interest. So it's either or on these. It's like demanding to do things that they shouldn't be or refusing to do things that they ought to be doing. A lack of sensitivity and socially inappropriate behaviors sometimes require intervention, particularly if it's in public environments. And sometimes being verbally aggressive requires some kind of an intervention. Not always, but often. So I'm going to give you an example of one of these kinds of behaviors, and going back to that framework I suggested, thinking about it both from the emotional experience of the caregiver, the behavior of the care recipient, and then the context in which it occurs. So the scenario or the case that I would offer as an example is an individual who has dementia and is being cared for by her husband. And the husband, the caregiver, is his context is that he has arranged a medical appointment, a doctor's appointment for his wife tomorrow morning. And it took him a lot of time to get the appointment, and it was, if he loses this appointment, it would be delayed some months. It was necessary, and it took some effort. That the behavior he's identifying is that his wife is refusing to bathe or put on clean clothes to go to the appointment. He's quite frustrated, and he's getting irritable with her as he's trying to get her dressed and ready to go to this appointment. And then he starts to think about what will happen if we get there and she's wearing the same clothes that she's worn 3 times this week. What do we do with this? How do we behave? What kind of consequences or what kind of interventions? How can I respond in a way that will diffuse the situation and not let it cross the line into an abusive one? So Mary, if you can advance the slide, the response is the kinds of things, once again, distract and redirect. Perhaps in this environment, it would be really helpful for the caregiver to say, let's eat breakfast first, then we'll go get a bath and put on some clean clothes. So in essence, you're doing an activity to distract and then try it again later. Sometimes not asking, please, would you like to, rather offer a direction that's more matter of fact. It's now time to get in the shower and take a bath so that we can leave. So intervening in more of a matter of fact way. Sometimes changing the environment around, moving objects or removing cues that cause distraction or get in the way of getting a job done, or changing things. Maybe taking the soiled clothes and putting them out of sight so that the ones that we're going to put on are the clean ones. Sometimes it's getting outside help, having a family friend or a family member come over, or hiring a caregiver to assist in those moments when you know you're really going to be sort of under pressure to get something done because there's some pressure to be somewhere or do something. Sometimes it's like, let that happen. Go to the medical appointments. Don't insist on the bath. Don't insist on the change of clothes. And then talk about with the physician or your medical provider about, here's the kinds of things that I'm struggling with. Is there any medical assistance that might be useful? It might be a change in medications or a change in the timing of dosing medications can make a difference in what kinds of behaviors you might be experiencing. So it's really about trying to dial in the response to the right situation so that you're not over-responding to things that don't need intervention, things that you can tolerate, but making sure that you do in a way that you're not going to become neglectful or having an aggressive response to the care recipient. Okay, and then moving on to level 3. These are behaviors that have physical, dangerous consequences in the moment, right then. This is when an individual might become physically threatening or aggressive or demand to do something that's clearly unsafe. For instance, someone with a moderate or severe dementia getting in the car and driving, when you know that that is clearly not something, they don't have a driver's license any longer, and is not a safe thing. Or if an individual has extreme confusion and you know that they could either hurt themselves or hurt someone else because they just don't understand what's going on in the moment. These are more rare situations, but certainly these are the ones that we know where mistreatment or abuse can happen either to the care recipient or sometimes to the caregiver. And I'm going to give you a scenario of a case that is not an unusual situation when we have caregivers who are taking care of someone with an advanced dementia. So the situation, again, is a husband and wife where the wife is the care recipient and the husband is providing the care. The husband gets up in the morning and realizes that he has had a very poor night's sleep because his wife has been up in the night searching for what she believes is lost jewelry. Folks with dementia, those of you who are caregivers know that people with dementia often believe things have been stolen when they can't find them. And they can't find them because they've hidden them away so safely that they themselves don't remember where they are. And that can lead to all sorts of problems, like being up in the night searching for lost items. So the husband is recognizing his own emotion that I'm exhausted and I'm irritable. He also recognizes that his wife is getting more and more agitated and more aggressive about, I want my jewelry, where is it? So neither of them slept well the night before, and he gets up and goes down into the kitchen and finds his wife in there searching for her jewelry, and she's got a knife in her hand, and she's gotten more aggressive with him. So what does he do? So then we switch over to the responses. What are some reasonable responses? We're going to skip over the plan part for right now. So the second item on the list, leave the house. If a caregiver is under threat, if it's so dangerous that you're worried about yourself, that there's that feeling of, no, I'm being abused, I am being mistreated, I am under threat, then you really need to leave the house, because if you're being harmed, you can't do anything else reasonable to help the care recipient. Call for help, go next door, find a family member or a friend or a neighbor who can help you out. Or maybe if there isn't that support available to you, call the police, explain the situation, get some assistance. It might be a time to start considering placement or hospitalization, or do we need some medical intervention, like a change in medicines or something that will dissipate these sort of extreme behaviors so that there isn't the risk that someone's going to get hurt here. We don't want to neglect or abandon the person, certainly, the care recipient, but we also can't do it when we're under threat ourselves. So getting outside help involved so that we have good responses and we have a good way of managing the behavior makes all the sense. The first item there at the top, to consider a plan before the crisis erupts, is critical. So if an individual is in that caregiving role for someone with more advanced dementia, you're seeing signs that there are problems erupting or evolving over time, that it's going to get worse, that we're starting to tip over, or I'm feeling less and less confident in my ability to manage what's going on, that's the time to make a plan before the crisis erupts. And it might be to call a family conference and say, I need help here, or to call upon agencies in the community where you're going to get some support and help to figure out what resources are available to you. But making the plan and recognizing, this is getting bigger than I am, or it's harder to do than I thought I could manage, then that's the time to really call in and see what I can do to get some help. When I have seen abuse or mistreatment unfold, it's not people who have malintent in their heart, but it's often people who failed to develop a plan before the crisis erupted. And before they know it, they're in the middle of the crisis and mistreatment occurs. So it's that planning, forethought, and kind of rational evaluation before we're in that crisis mode that really can save the day. Okay, if we move to the next slide, I'm going to just give you some general behavioral management strategies. These are very vague and they apply across all three levels of intervention. Lots of times what we say to caregivers is to, when there's a difficult behavior, to first distract them from it, because folks with dementia, with the memory problems that go with it, often will forget the issue that they are focused on that's generating that difficult behavior. So just distracting to, could you help me over here with this, or can we go into a different room, or can you, whatever the distraction might be, redirect them to a different task. Could you help me unload the dishwasher or fold the laundry? Or would you hold this door for me while I'm taking the trash out? Whatever it is, but redirect them to another activity. Doesn't work every time, but it often does. And I'm going to guess usually about 80% of the time. That's my experience. About 80% of the time, these kinds of strategies work to dissipate the behavior. Change the scene. Go in a different room, get in the car and go out to the grocery, or do a chore or a task outside the home, or go outside, water the lawn, or whatever. A change of scene that you can arrange for can dissipate the behavior and not cause it to escalate into something that could be more dangerous or difficult. It often just does not make sense to argue with the person about why their behavior is inappropriate in the moment. It just doesn't help. Folks with dementia do not understand the reasons why their behavior is inappropriate. So arguing or explaining or reasoning with them around it is often futile. And it's one of the hardest things for caregivers to come to accept, because human nature being what it is, we all assume that the way we're thinking about something is the way that other people are going to think about it. And with dementia, that just doesn't apply. So it's a very, very hard lesson to learn, and we often, as caregivers, learn it in small increments, not to argue, reason, and explain. Someone from the Alzheimer's Association offered to me this acronym to help caregivers remember this, and it's so useful. So it's these little word R, A-R-E. These are the things we don't do. We don't argue, we don't reason, and we don't explain. And it has helped me a great deal in working with caregivers. Okay, and to the next slide. In some closing thoughts, just sort of in summary, I would, as for those of you who are caregivers or working with caregivers, encourage you all to plan ahead to avoid that really big crisis, avoid the negative, horrible outcomes that we're trying so hard to avoid by planning ahead. But that said, to stay in the here and now, enjoy the parts that we can, find something that we can be grateful, something that's good about what's going on right now. To take the time and recognize when something goes well, when there's that moment of levity or that smile that you haven't seen for 6 months, or a funny event that occurs, or a day that just goes pretty smoothly without a whole lot of hiccups and lots of bumps in the road. Sometimes it's really good to just find that and recognize it and kind of feel good about what hasn't gone wrong. I found that in caring for my own mother that I had to work hard to notice the aspects of her that were not affected by the disease as the disease progresses. You know, we kind of tend to focus on the symptoms and the disorder, and sometimes we forget to look for the part that is not affected by the disease, the part that's sort of still her or still presents the parts that you love and care about. And I think if we just kind of remind ourselves to really look for those parts as well, it can really sustain us in the long run. So it's hard work. It's ever so respectable and honorable work in caregiving, but really tough. And so I encourage you all to really take good care of yourselves as you engage in those important tasks. So I'm going to turn it back to Mary. I think she has some resources for you.
Thank you so much, Bonnie. And yes, I just wanted to direct people for more information, whether it's about research related to elder abuse, training curricula, public awareness materials. You can find all of those on the National Center on Elder Abuse website. And I'm going to turn it back over to Laura Bauer.
All right. Thank you very much. That was some really, really good information. A couple of people have asked me would they be able to have the slides. We're actually recording this webinar, and it will be archived. All of you will get the link to it, so you'll be able to listen to it and view it, plus I can send you the PowerPoint as well. I'm waiting to see if Cliff Burt or someone from the Georgia Division of Aging Services is on the line. I haven't had confirmation yet, so if they get on, please either raise your hand or in the chat let me know you're on, and we'll give you a couple of minutes. But in the meantime, while I'm waiting on that, if anybody has any questions, would you please now type them in the chat, and we've got time to answer a few. So please go ahead and ask your questions now. And I'm sure somebody out there has got a question, so don't be shy.
Laura, while we're waiting for a question or for the representative from the Georgia Division on Aging, I didn't know if maybe Bonnie might tell people a little bit about a project we're doing where we're sitting down with caregivers.
I think that's a good idea.
Okay, I'd be happy to. One of the, we have two different grants actually that are looking at caregiving and elder abuse, and what can we learn and how can we help the caregivers so that they don't inadvertently end up being abusers. So one of them is to help us learn how to present educational material to caregivers so that it's both compelling, educational, and informative, so that they learn about elder abuse in the best way in their language that makes sense to them. So in order to do that, we're conducting interviews with caregivers, and we've selected particularly caregivers who don't have a lot of experience with like caregiver support groups, and they're sort of at the beginning of the I need some resources here in order to do a good job, so that they're what we call naive, that they haven't been exposed to a whole lot of support services, and having them tell us what their experiences are and what the language about elder abuse and mistreatment can be, so that it's most effective, that we can reach this audience and help to educate them about the warning signs and the things that they can do to protect themselves and the care recipient. So that's one of the projects, and the other one is,
yes. I have some questions now, so before we run out of time, do you want to ask some questions? The first one is from Melody Adams, and she says, how often do the elderly make complaints in Texas?
So I did a quick Google search to answer your question, Melody, and so of course Texas Adult Protective Services, so I'm sure you know who they are, the social workers who you can report to. We can report suspicions of elder abuse to. They completed 87,741 investigations of abuse, neglect, or exploitation in Texas in 2011. That's the data. That's the most recent. And of those cases, 58,000 were confirmed as valid, so they were substantiated. And I didn't have time to figure out what percentage is 58,000 of 87,000, but that's what that says on their website.
Okay, thank you. I also have a question. What if you have had or know of abuse and you report it to APS but nothing is done? Then what can you do?
Maybe I can respond to that. This is Bonnie. I understand that situation, and in the community it can be extremely frustrating because you know the expectation is that they will make it better. And I know firsthand that because I go out with those APS social workers and do assessments with them hand in hand, and often because of laws or policy we're limited in what we're able to do to intervene. Even when we see mistreatment or abuse unfolding, there are times when we just don't have any mechanism to intervene properly. So what do you do? How do you respond? What's the next step? I think that it makes sense if the abuse is related to issues of caregiving and dementia, and I'm going to restrict it to those scenarios because that's our topic today, that it makes sense to reach out to those community agencies where you can have resources to help support the caregiving role. And that might be the Alzheimer's Association in our community. It might be, we have the Orange County Caregiver Resource Center. It could be, Mary, are there other more nationally based agencies that people can reach out to?
For if they
for like caregiving support.
Well, I see there's another question. Is there a caregiving hotline?
Yeah, let's answer that one, and then I'm going to put Cliff Burt from Georgia Division of Aging Services on.
Okay. I would just say that there are wonderful groups like the Family Caregiver Alliance, like the Alzheimer's Association, for people to access. But we can turn it over to you, Laura.
And someone said they can, Holly Glover from Texas says they can contact the Area Agency on Aging as well.
Yes, thank you. Yes. That was the term I was looking for in my mind. Good.
I'm not sure which line is Cliff, so I'm going to unmute everybody, and then Cliff, if you can go ahead and take it away.
The conference has been unmuted.
Good afternoon. This is Cliff Burt with the Georgia Division of Aging Services, and we have colleagues in the room, and we wanted to share with you some information regarding the development we're underway with for abuse, neglect, and exploitation. Cherie Rines with our Adult Protective Services Unit is going to give you a brief overview of what we're doing.
Hi, this is Cherie Rines. I just wanted to let you know that currently we have in progress, we're developing an app, an ANNE app that we're calling the Georgia Abuse, Neglect, and Exploitation app, or GAIN, and that we were inspired to do this partly by Minnesota because they had a financial abuse symposium that was put on by Wells Fargo over a year ago, and when you have these symposiums, everybody kind of vows to do something to combat the issue over the upcoming year, and what they did was develop an app, And so when we had our symposium and heard about that, we thought that maybe we could do something similar for Georgia. And what we ended up doing is that we're going to look at financial exploitation, but we have expanded it beyond just the preview of financial exploitation. And we're going to focus on some education of the public on just general abuse, neglect, and exploitation, have resources out there for them to know who to call if a person is in a facility in Georgia, because for us, that they would be calling the Department of Community Health, and if the person is in the community, they will be calling APS. We also have some other resources that are specific to law enforcement and APS, as well as some screening tools to kind of help APS and definitely law enforcement to figure out when they encounter vulnerable adults who may have some cognitive issues or who may have financial capacity issues, to figure out how they best can serve that person. We were particularly moved by some incidents that happened over the winter where an elder person had been pulled over by law enforcement, and they felt that something wasn't quite right, but they wasn't sure, and then they let that person go on, and we had some not so great outcomes for the individual. And so law enforcement has been kind of crying out, so how do we know when we really do need to prevent that person from going on and try to get with family members and have them come to the aid of the individual? So we've been working with a doctor out of Emory University and also been working with a researcher out of UAB to get some tools, some quick screening tools that officers can access on their phones through an app to help guide them in how to make these decisions when encountering vulnerable adults out there in the community. So that's just a quick overview of what we're trying to do in Georgia to help combat abuse, neglect, and exploitation.
Thank you very much for sharing that with us. I really appreciate it. We had one more question that I don't think got answered. If we have time to stay on another minute or two. Are you seeing an increase in elder abuse and a lack of respite? Bonnie or Mary?
Yeah. Well, I'll take a stab at that. This is Bonnie. It's very difficult to know if the incidence of abuse is occurring at greater rates or if there is an increase of awareness and so it's being reported more readily. So those are hard questions to answer. I think the idea of respite care is something that becomes really important in the caregiving context where abuse might happen. I know in California we've been struggling to develop some emergency respite environments where folks who have been, and we know have been mistreated and are not being provided adequate caregiving, a place where they can be put safely until resources are sort of brought to bear. So sort of that kind of emergency housing for folks with dementia. So I think we are looking at it and we're trying to organize those resources so that they're more readily available. I certainly, in working with caregivers, encourage them to plan for those times when they need respite, to bring resources to bear that they have available to them, whether that is family, friends, neighbors, or such, but to plan for the need for respite.
Thank you very much for answering that question. And I hear and that's because everybody's unmuted, but we've run out of time. I just want to remind everyone I have your email addresses, so I'm going to give you a link to this webinar as well as the PowerPoint slides. And you can also contact me. I will send you that information. And if you have any further questions, we'll be happy to get back to you on a one-on-one basis. And we appreciate it. Thank you very much, Bonnie, and thank you, Mary.
All right, thank you.
It was a pleasure.
Take care. Bye-bye.
Thank you. Bye-bye.
For the win.